She, I was mentioning, she was a 57-year-old woman. She came in for secondary opinion about weakness that had been going on for about 9 months at this point. Specifically, bilateral painless leg weakness. She'd mentioned having trouble getting up from a chair, difficulty going up and down stairs. More recently, she was noticing some weakness with her grip strength and finger strength, and she was having some difficulty with projecting her voice as well. And then just kind of through talking with her, I also found out that she'd had about a 35-pound weight loss over the last 6 months. So her past medical history, nothing really too significant. She had high blood pressure and she's taking amlodipine for that. No really other medications. She did have a 30-year PAC history of smoking and occasional alcohol use. Then since she had seen 2 other neurologists before seeing me, she had some testing with her. She had an MRI of her lumbar spine, really just showed some mild arthritic changes. She had also had an EMG completed, which I didn't have at the time of her visit, but I got later. And it showed some really severely abnormal motor responses on the nerve conduction study of low amplitude. And then interestingly, the needle exam showed some increased insertional activity as well in all the muscles tested. Her blood work that she'd had done really didn't show anything too significant with her inflammatory markers. And so on her physical exam, she did have some weakness, mild weakness in her grip strength and proximal lower extremities, a little bit worse on the left side. But she did have normal bulk and tone, no abnormal movements. Her sensory exam was normal. On her reflexes, they were traced to absent throughout. And then she had no rashes on her skin. So at this point, you know, she had come because there was a question of could she have some kind of irritable myopathy. They were thinking about wanting her to get a muscle biopsy. I was a little bit concerned about her weight loss and her smoking history. So I ended up getting a paraneoplastic panel and I was planning on repeating her EMG. And so when I got the panel back, she did have positive antibodies for calcium channel antibodies, both N-type and PQ type. And that prompted me to then get a CT of her chest, abdomen, and pelvis. And that came back, unfortunately, did show that she had multiple pulmonary nodules and as well as some nodules in her right breast and in her kidneys. And so she ended up being referred to oncology, and she had a bronch with biopsy confirming small cell lung cancer. So this is just a view of her CT, and that's kind of showing the biggest pulmonary nodule there. So her final diagnosis, Lambert-Eaton syndrome, and just to kind of go into Lambert-Eaton a little bit, it is a disorder of the neuromuscular junction. Patients are going to present with usually painless muscle weakness that can improve with repetitive movement. They may mention having difficulty with standing from a seated position, with stairs. It is typically symmetric, more proximal than distal. Later on in the course, you can have oculobulbar weakness. So she did have some difficulty with projecting her voice. You can have some autonomic dysfunction and respiratory failure, which she didn't have at that point. And areflexia is actually a really common finding on exam, which she did have. And then the antibodies against the voltage-gated calcium channels occur on the presynaptic nerve terminals, and that basically is going to decrease the acetylcholine. And so about 85% of patients are going to have the PQ type antibody, which she did have, and then rarely you can have the N type seen with malignancy, which she also had. And more than half the cases of Lambert-Eaton are associated with small cell lung cancer, but also consider thymoma, prostate cancer, and lymphomas. So symptoms can precede the cancer diagnosis by 5 to 6 years, but her symptoms, I think, had actually been going on for longer than about 9 months. than she realized. And risk factor is definitely that smoking. So that smoking history for her it is typically more common in men, but obviously can happen in women as well. She was started on pyridostigmine, but other options include the 3,4 diaminopyridine. IVIG, prednisone, and Plex are also occasionally used. For prognosis, treatment of the underlying malignancy can improve some of the weakness, but unfortunately, often full recovery is not seen. And typically there's poor prognosis with more advanced cases for this patient. Unfortunately, she was given about 6 months without treatment of the cancer and 1 year with chemotherapy. She did choose to start chemotherapy, but she wanted to seek treatment closer to home. So she is getting treatment with oncology in Charlotte. And that is it.
Great case. Thank you, Nadisha.
Okay. Deb, this is Rich. I was going to do the introduction, so let me share the screen. All right, everybody, sorry for the mess up this morning. So today's grand round speaker and a very important member of our department is Dr. Deb Addix. Deb's an associate professor in psychiatry and neurology, but everyone knows her as the director of the cognitive testing and neuropsych service within the department. Deb got her PhD at the Alliant International University. And she's managed to have a career that spanned many different things, including NFL and head injuries, college football. But the thing she's most passionate about is something that emerged from her love of international traveling, and that is the role of location and country on epilepsy care, cognitive testing, and patient outcomes. Her research for this has been funded by the Bass Scholars, which is a very highly selective program at Duke. And Deb has worked with both neurosurgery and neurology as part of this. And we look forward to her talk today, which is understanding the landscape of practice and epilepsy care in Uganda, Africa. So Deb, I'll turn it over to you now.
You're muted.
Me or Deb?
All right, you can hear me?
Yep.
Yes.
All right, and how's that look? All
Very
right.
good.
Okay, so good morning, everyone. Nice to see some familiar names up on the Zoom screen, and also I saw some of my colleagues in the Division of Global Neurosurgery. I think Mike Hagland and Tony Fuller are on the line. So if any hard questions come up, I'm going to share the job. But really, I'm going to be spending the next 45 minutes or so just telling you about our work in Uganda, Africa, and what we've learned from it in terms of the importance of understanding the landscape of practice. And I chose this topic largely because the much of the work that we've done recently has been in really doing a deep dive and understanding the cultural context of the work that we do in Uganda. But also because I think that it's an important time in all of our practices to really think about how well are we really understanding our patients' experience. and the things that impact their healthcare seeking, their healthcare outcomes, their treatment adherence, and then, of course, all of the emotional and well-being kinds of outcomes that we are always dealing with as our patients come back to see us. And I would say that everything that we looked at in Uganda in trying to understand our patients, from what their belief systems are to their family situations, income and education, these are all things that we here in the US, when our patients come to see us, also need to try to appreciate and not make assumptions about. This work was funded largely by a generous grant from the UCB section of societal responsibility, but also I've had a series of Bass Connections grant through Duke University. We just got our 4th iteration funded for the next piece of work. So as I tell you the story of the landscape of practice research that we did, you'll see the various iterations of the Duke Connections grants. And if you're not familiar with those, it's there's small grant funding, but small grants go a long way in East Africa, but also they're really seed grants to help students become a part of the scientific process of solving real world problems. And it's really, really rewarding to work with a bunch of students on these kinds of projects. So just a shout out for Bass. Okay, let me see if I can advance. For some reason, I'm not advancing. I'm gonna stop share and reshare because it's not working. Little technical difficulties from the get-go. Okay, so part of the reason that I love working with the Department of the Division of Global Neurosurgery and Neurology is that there is definitely this attitude of go big or go home, and also to whom much is given, much will be required. These are Dr. Mike Haglund, who is the director of that division. Famous quotes, we hear them all the time. And the work that's been done that predates my joining the group has been quite incredible. And I'll talk in a moment a little bit about that. Basically, Dr. Haglund started doing neurosurgical service work and teaching in 2007. A joint Duke School of Medicine and Makerere University neurosurgical training program was set up with the purpose of trying to expand neurosurgical capacity in Uganda. When they started, it's my understanding that there were 4 neurosurgeons in a country that was serving roughly 40 million people, now up to 43 million people. There are now, they've doubled that number, and they are graduating two, I think, new neurosurgeons per year. So it's really quite a infrastructure, a strong program that is partnered across 2 universities that is having some success at increasing capacity and facilitating access to care. The actual Division of Global Neurosurgery and Neurology in the Department of Neurosurgery was formed in 2014. And then in 2017, Dr. Haglund got a grant to do capacity building work and building centers of excellence in epilepsy care in 2017 through UCB. And that launched the work that you're going to see here. I don't have to explain to this group what epilepsy is, but what I will mention is that these are WHO statistics that are a little bit off at this point. The current statistics are that we're approaching 70 million cases of epilepsy globally, and the epileptologists on the call know that that a disproportionate amount of those cases live in low and middle income countries. About 80% of those do, and that 3 out of 4 people in those low and middle income countries do not seek treatment or do not get the care that they need. Those numbers in the United States are incredibly different. The situation is far better. In East African countries, there's a great deal of misunderstanding about what the disease is. There's a great deal of stigma and discrimination, and these are some of the things that we're going to talk about because they feed the treatment gap. Epilepsy, as you know, is incredibly treatable, incredibly easily treatable, and yet getting people to the right care is a challenge. So, when we started working in this space, whether it was to actually start building epilepsy clinics or understanding the practice landscape, there obviously needs to be the whole project has to be approached with some cultural sensitivity, understanding that being in that space is a privilege and not a right. And I think that there needs to be respectful mutual education. And it takes some time, but building trust through excellence in our work and responsibility are key components to not setting up sort of like uh, to have a mutually beneficial, hopefully eventually self-sustaining program where access can continue to be facilitated, and the presence of outside support wouldn't be necessary. Again, here I ask you to think about your own practice and your own cultural sensitivity, your understanding of where a patient is coming from, your mutual respect, and then mutual education and communication about your experience and how you build trust by showing up with excellent care, responsibility, and some cultural humility. And basically, how can we serve if we don't understand our patients? And the concept that it's not so much cultural competence that I think that we're seeking as it is cultural humility coupled, with emphatic curiosity. That's actually Dr. Neil Prose, who has done a lot of global work, talks about this emphatic curiosity and cultural humility. So it's the idea of not thinking of, I got this, or I've done enough training with this certain population that I understand, or any of that kind of thing, but instead really meeting our patients where they are and trying to listen to them and understand their experience with the attitude of knowing that we don't understand their experience and what we can learn from them, and then how that might modify our treatment plan, our assessments, and our ideas about are they able to follow a certain medication regimen? What can we yoke their medication regimen to that would increase their success and things like that? And ultimately, when we want to grow in understanding and effectiveness through this work. So we did a bunch of research through 3 years, looking at what the barriers to care are for patients in Uganda seeking epilepsy care. We studied the stakeholder perspectives, the impact of belief systems about causation, what's expected in the public hospital care system, and then what are the sociocultural determinants of healthcare choice, and then what's the vision forward. We were fortunate at the end of this to be able to publish a special issue of Epilepsy and Behavior that came out in the beginning of this year, summarizing it. And one of the biggest, I think, blessings about being able to publish this in this manner is that this is now an advocacy tool that can be used by our partners in Uganda in their conversations with and advocating at the Ministry of Public Health in trying to get resources and infrastructure built for epilepsy care. It's sort of a special issue that says, this is what epilepsy looks like in your country. I just wanted to acknowledge my close colleagues, especially Drs. Hagland and Fuller and Coles, worked very, very closely on the projects that we're going to describe. And then there's a host of our colleagues over in over in Uganda that also are key in all of this. And then all of the students that you see on the right side through the years also helped with these programs. And here's Duke Neurology and Neurosurgery over in Uganda after one of the surgical camps. And then this is the epilepsy, the core epilepsy faculty team. So the projects that we did started by looking at what the barriers to epilepsy care in Uganda are. And then we expanded that to look at the needs and perspectives of epilepsy healthcare providers on the front lines. Excuse me. And then currently we're doing some healthcare provider education to reduce the epilepsy care disparities. And I'll explain what that program is. And then next we're going to move into community sensitization to improve epilepsy healthcare literacy. I'm going to be talking about 3 distinct samples. We did a number of focus groups and interview studies with a sample size of about 126 in total. We did systematic objective survey data collection on a hospital sample of 626 patients and their caregivers. And that sample, it's important to recognize that that sample overcame the barriers that we're going to talk about because they're in traditional allopathic hospital care. And then we also surveyed a very, very large community sample that we accessed through a door-to-door randomly selected prevalence study sample. So at the time that all of this was going on, we were also doing a national prevalence study, which gave us access, very broad access to community members. And so we gave them the same surveys that we were doing in the focus groups and in the hospital sample. So we now have probably one of the biggest, if not the biggest, sample of epilepsy beliefs and practices in East Africa. And this is the data that we used to come to the conclusions that we did. So we started small with our qualitative studies. And for the residents and those who are newer to research, it's important to recognize that the value of these qualitative studies is that you learn what you don't know more than what you do know. In constructing surveys, you're constructing surveys based on what you think you know or what's already in the literature. But when you sit down with open-ended questions to ask people what their experience is, you learn about things that, I hadn't even thought of that. And, oh, that's not in my survey. We need to add that. And so it's an important part of doing research when one doesn't fully understand the landscape. So this was my BAS1 student team. We went over to Africa for 2.5-3 weeks to do some qualitative research. What we did is focus groups and interviews in stakeholder groups, including patients and families, neurologists and psychiatrists, traditional healers, and pastoral faith healers. And what we learned is that from their perspective, the major weaknesses were the lack of clinics and resources, drug stockouts, which is basically that the flow of AED medicines stock out usually once a quarter, where the drugs just are not available in the typical places of distribution, which is actually in clinics and hospitals. And in those cases, the epilepsy patient is basically either given a partial rather than a month's worth. They might be given a week's worth, and they will be encouraged to try to secure the rest of the drug through clinics, but they have to pay for it. And as you'll see shortly, the income of most of these patients don't allow them to do that. Or they may have to switch medicines, which, as you know, with epilepsy is not easy to do just on a whim. The quality of the drugs, sometimes there's counterfeit medicines, and those are also issues. Stigma, the lack of understanding of epilepsy as a brain disorder, lack of collaboration between traditional healers and allopathic medical healers, and beliefs about witchcraft and demonic possession or ancestral determination are major barriers. All of these stakeholder groups talked about solutions, including dedicated epilepsy clinics, consistent access to medications, collaboration, and then, of course, community education and sensitization. We didn't in BAS 1 include the frontline healthcare providers. So in BAS 2, we went and interviewed people who were on the front lines of care. We interviewed non-specialized, so non-neurologists, non-psychiatrist providers. And it's important to recognize that in that country of 42 million people, there are only 11 neurologists practicing and about 35 psychiatrists. And these are the folks that either directly treat or oversee the treatment of patients. And then the rest are treated by general physicians, medical clinical officers, psychiatric clinical officers, and so on. So those were the folks that we talked to in this study. And I just want to acknowledge my colleagues, Dr. Fuller and Dr. Kakuza, and especially Dr. Fuller, because during this cycle of research, I became quite ill. And he picked my students up and took them and executed the project that we had been developing, and then came back. And then together we were able to collaborate in analyzing that data. And basically we also did patient participant proficiency ratings to find out what they felt comfortable with in terms of their knowledge and expertise in epilepsy and what they felt they needed more help with. And then they gave that information to us about, augmenting resources, infrastructure strengthening, and then providing education, sensitization, and support. And then this helped us in the current project where we are developing or trying to augment an epilepsy module that was put together by the Ministry of Health, the World Health Organization, that is used to train new providers in across Africa and India. And it's called the Mental Health Gap, the MHGAP program. And as we're working on BAS 3, we're augmenting that MHGAP epilepsy module, considering what our providers told us and what they're comfortable with and what they're not comfortable with. So now I'm going to talk about the hospital sample a little bit and what we learned from them. And all of these all of this data is a part of the special issue that I talked about. And Tony Fuller headed up the analysis of what's typical in hospital care, what medications are used at the different centers. We focused on national psychiatric, national medical, and regional medical hospitals in recruitment of this sample. You'll notice that 92% of the sample loses consciousness when they have their seizures. And about a little bit over half of the sample is reporting that they have developmental or learning delay. So we're dealing with a pretty sick sample in terms of having a high severity of seizures. And so you can see the number of AEDs that the sample is on. People that have less frequent seizures and less debilitating seizures don't necessarily make it to care. So that's one important message. And you can see that it's really first generation drugs that are used in the public sector. In the private sector, it's different because the money flow is a little bit different, but over half of the population in Uganda uses the public sector care, and it's the first line medications that are used there. We took all the barriers to care that we heard in the qualitative studies, and then also some additional ones that we suspected were also in operation. And then we asked patients using Likert scales which ones mattered in their journey to care, if they reflected on what it took to get them to see an allopathic healthcare provider, And the ratings came out in this manner. And what you'll see is, so we took all of these scores that were given and we analyzed the intercorrelations and we reduced the data here into factors. These were the factors that emerged from those barriers to care. And cost covers both logistical as well as actual cost of care. So what does it cost to leave your job for 2 days to try to get on a boda moped motorcycle or walk 30 kilometers to the clinic to get care? This was the one that turned out to be an issue for almost half of the sample. Issues related to faith in the doctor's care or the time that the doctor takes with them was a part of it. Beliefs about treatment effectiveness, the influence of family members or community members, and then contextual factors like being able to leave their job to seek care or their belief systems in terms of treatment adherence. These are how the barriers played out in the sample. And this is important because we recognize that if we're going to do an intervention trying to get people to care, those focused on cost, actual and logistical, are the most important to target. So again, it sort of helps to guide us to think about where should we aim if we're trying to make a difference. We also asked people about their belief systems, about single versus pluralistic attributions for epilepsy. What we started to really appreciate is how people think about what causes the illness impacts how they seek care. And so in the unaffected community sample, we wanted to know how people thought about epilepsy and how they perceived it. So this is in the large sample of the Ugandan, randomly selected Ugandan community. You can see this is randomly selected, right? And the income level, 70 or so, 3 out of 4 people are making up to 20 Ugandan shillings per week. That's about $5. So $5 or less. So when drug stockouts happen, and patients are encouraged to go privately seek any kind of missing medication, and the drugs cost $1 a day, this is the perspective we have to keep, that 3 out of 4 people make $1 to $5 per week for their family to live on. So really, access to medication and a regular medication supply is so important. What we learned about causal factors, here again, we asked them about, do you believe that malaria can cause epilepsy, injury to the brain illness, trouble in the home, the sun heating the brain, punishment by God, witchcraft? And we asked people, do you believe that these things can cause epilepsy? And they didn't have to endorse only one. It was not mutually exclusive. If they believed any of those could cause epilepsy, they could endorse it. And that was a new piece of research, because typically when the research is done, it looks at exclusive beliefs. And it's important, we learned, to not do that, because the amount of pluralistic beliefs is just incredibly high in the system. So the factors that emerged were belief in biological factors like high fever, malaria, injury to the brain, biospiritual factors, and those are like, there's some biological link like the sun heating the brain or the blood in the person's abnormal, but there's a spiritual component to it. It doesn't follow what we know about etiology of brain behavior. And then third, the socio-spiritual factor, and this is the important factor we'll find out a little later on. If the population believes that witchcraft or spells or spirits possessing the person, or that the ancestors are causing the epilepsy, then we name those as socio-spiritual. Then we looked at, in the population, how often does the population, and again, this is randomly selected, believe in these various factors. Only 1 out of 5, 22%, endorse the biological factor alone. 7% the socio-spiritual factor alone, and 3% the bio-spiritual factor alone. The remainder of the sample endorses a combination of 2 or all of these factors as being potentially causal of epilepsy. And so basically 2 out of 3 people in Uganda believe in a pluralistic possible etiology for epilepsy. And you'll see in a minute why that's important. What I was really interested in doing is looking at how these barriers to care and how these belief systems impact healthcare seeking. We know that some people go to biomedical care first. They start there and get biomedical care as soon as epilepsy shows. That's about 57% of the sample. This is, again, is the sample of folks that made it to care eventually, the 626 people. 37% of those folks sought care through a traditional healer first, and 7% went to faith healers. So almost half of the sample is going to make a stop elsewhere before they make it to biomedical care. And then part of the reason this is so important is the average delay to biomedical care, if a stop is made, is 2 years, right? So if you can imagine sort of being untreated for 2 additional years and all of the stigma, discrimination, and risk for injury and burns that happen during that time, it's just incredible. And so we wanted to understand, well, who's going where and why. And when we also recognized that this would potentially be a complicated relationships between predictor variables. So we put all of these variables in, the demographics, the seizure characteristics, and the beliefs and barriers into a logistic regression, as would be traditionally done, to try to figure out, well, which of these variables really made a difference in predicting who went to biomedical care versus elsewhere first. But then we also did some fancy statistics because we had a brilliant statistician with us who used factor analysis to reduce the predictive variables and basically came up with these principal components that hung together. So principal component 1 in the data really recognized that the barriers that we had identified of the barriers to treatment hung together in endorsement, right? PC3 was this very interesting predictor that was a combination of this consistent finding between loss of consciousness and caregiver education, and sorry, not loss of consciousness, caregiver education and household income, and then beliefs, this anti-correlation with biospiritual or socio-spiritual causes, and then some onset and seizure frequency indicators. And this principal component analysis, once the principal components were entered in as the predictors of who went to biomedical care versus traditional healers, this PC3 was the one that was predictive. And so the bottom line is that a pattern of high income with low beliefs in non-biological causes of epilepsy predicts who goes to biomedical care first. If you have low income, low education, and high belief or likelihood of belief in spiritual causes of epilepsy, then you're more likely to go to a pastor or to a traditional healer. And then the average delay to reaching biomedical care is 2 years. So as we next year get into trying to increase healthcare literacy about epilepsy, this research is going to be pretty important, because we know that a very, very large percentage of the population does believe in ancestral determination of outcomes of health. We know that a large percentage of the population believes in the potential of witchcraft or demonic possession also being causal. And so if we can address those belief systems in a culturally sensitive way, we may be able to get people to care faster. The last study that I'm going to say that we did is in this unaffected large sample, we asked people, should patients have basic human rights? Should patients with epilepsy be allowed to marry, go to school, play with others, be a normal part of society? And you can see that in the unaffected sample, there's a huge, almost half of the sample say no, they should not be allowed to marry. They should not be a normal part of society. Children should not be allowed to play with others. Why is that? Well, a huge amount of the population believes that epilepsy is contagious. At the highest level, when one is having a seizure, but even when they are not having a seizure, there's 1 out of 4 people believe that if you go near a person with epilepsy, that you yourself can catch it. And if you think about the world we live in now, where we're dealing with a contagion and how disruptive and how scary it is, you can imagine that basically people with epilepsy in Uganda are treated that they're carrying a contagion, one that's very dangerous and that can seriously alter the course of one's life. So there's a great deal of discrimination, of isolation, and of cutting that person off from society. We summarized all of the work that we did and sort of built a roadmap of moving forward to close the special issue out. And the intention of that work is hopefully to use that with the Ministry of Health in moving forward epilepsy care, expanding access through clinics and hopefully neurology posts, as well as education of providers. Certainly one of the things that I always like to just nod to is the perseverance of the human spirit in moving through these things, doing the work with the Division of Global Neurosurgery and Neurology at DGNN is humbling and amazing, because in these settings, children find a way to play, people find a way to get care, and of course the spirit of belief and family can be seen everywhere. And so it just is sort of right sizing to do this work and to try to be effective. In terms of current projects, there is a national prevalence study that is we're going through the final validation phase. In the current BAS group, we are taking that MHGAP epilepsy module and dukifying it and expanding it and adding patient provider communication sections, as well as a prescribing rubric. And we have a clinical epilepsy team doing a study on medical adherence. I'll talk about these for just a minute. Dr. Fuller really is the head of this project. But basically, we worked with the Uganda Bureau of Statistics to identify enumeration areas. In each 30 households were randomly selected, and every household member in those 30 households were invited to participate. In the end, almost 9,000 households participated, and we had 35,000 individual responses. And those 35,000 of those that where the epilepsy was adult epilepsy were the ones that we were able to survey with the psychosocial or behavioral barrier studies as well. We had different screening levels, and the second more narrower screen yielded a prevalence of 2.09. And then we also learned that there's major regional differences in epilepsy prevalence, with some estimates as high as 10%. We are currently doing the clinical validation of that study at present. The healthcare provider education, my partner in that is Dr. Neil Prose, who I mentioned before, and we have a great student group that has joined that ones. We always have partners on all of these studies. Of neurologists and or psychiatrists over in Uganda. And then we also had consultants from the Duke Epilepsy Division helped us with this. because we focused here on designing a better prescribing rubric, and then also had, as I mentioned, the patient-provider communication material that we designed. And really the point of that was to get we're now going to be training the trainers to increase access to people who have been trained in epilepsy care. And we want people to talk to their patients about their belief systems and about traditional healers and their use, because it's always a challenge for providers to make sure that there's not drug interaction factors when patients see traditional healers that are herbalists that may give them plants or teas and things like that that do have AED properties. And so being able to sort of get the story from the patient on who they're seeing and why, and then explaining the illness and then negotiating a treatment contract is something that needs to be done very explicitly. And then the prescribing rubrics, we were trying to resolve differences between the World Health Organization's MHGAP program and the Ugandan guidelines. And then the Ministry of Health is excitedly waiting for us to finish this material up. We're close to that so they can incorporate it in the national rollout of their program. I'm going to skip the next few slides, but it basically shows what we were working on. Here's some traditional healers in Rwanda. And then these are the slides that are going to be incorporated in about asking about traditional healers, but we're running short on time, so I'm going to move forward with this. The Medication Adherence Project is a team of students where we're looking at, again, what are the things that might impact medication adherence, from the use of traditional medicines to their health literacy, their beliefs, faith healers, their distance to medicine, and income stockouts. Because again, the better we can understand the variables that are impacting whether patients are taking their medicines or not, the more we're going to be able to effectively support them in their care. In the midst of all of this, in October 2019, we opened the first dedicated epilepsy clinic in Uganda. To date, about 2,500 patients have been served in this clinic. Out of everything that we've done, I think I'm most proud of this because there's a dedicated space for people who need care to go to. And just the sheer presence of the clinic with outside saying we care for patients with epilepsy, I think stands in the face of community beliefs about what epilepsy is. This clinic is situated in a regional referral hospital in Western Uganda. The regional hospitals are the step down from the national hospitals, so they serve a great deal of patients. So having a space in a medical facility where epilepsy is treated is a really big message to the population that this is where you get care for this illness, not at your local church or at the local traditional healers workplace. Next, things that are coming, we're very hopeful. We got an incredibly good score on a Fogarty grant that was submitted to characterize epilepsy and its comorbidities in Uganda, focusing in on the adolescent experience of those comorbidities like psychiatric disorders, suicide, depression, anxiety, and their experience of stigma. And then to co-create with those adolescents and their communities interventions that might work to increase the health literacy of their communities to reduce stigma and discrimination. We're going to couple that with the next iteration of the BASS grants to work and pilot some of those community sensitizations ideas. And then we just a few weeks ago were one of the finalists in the Epilepsy Foundation Shark Tank Award where we had pitched creating an app for adolescents in their communities, which focused on self-management of seizure tracking and medication adherence tracking, but also resilience building through doing awareness of mood and social functioning ratings, and which would then trigger potential different types of resilience building types of activities. And so we went and we pitched this, and here's Dr. Fuller and we won that award. So we're going to be developing that with our partners at the College of Information Technology at Makerere University in Uganda, because $25,000 goes a lot farther in Uganda than it does in Durham, North Carolina. And so while we couldn't build an app with that kind of seed money here, we certainly can there. And then we can pilot it and potentially bring it back to the US. So I'm just going to close with this idea that I opened with. When we take a step back and think about what we've learned through doing these surveys and these focus groups, we really understand what the barriers to care are. Many of them have to do with cost and with logistics in reaching care, the lack of infrastructure, the lack of clinics, and the inconsistent drug availability are at the top of the list. Healthcare literacy and the belief of epilepsy as a contagion is one of the main things that we need to target in our healthcare literacy programs. So in doing this initial work, we're not just trying to fight all of the tidal wave things that impact people reaching care in East Africa, but we can focus in on those things that we know really drive where people go for help and whether they go for help. And it gives us a place of potentially being effective. So that's our story. I encourage all providers to think about the stories of the patients that are coming to see you, because each of them have their story as well. And the more we understand them, the more I think that we can be effective in how we take care of them. So I'll open it up to questions.
Thank you, Deb. So if anyone has a question, again, either type your name or your question into the chat, and we will get to you. Deb, what would you say the most surprising thing you found in your time in Uganda regarding epilepsy and people's belief in it?
I think the really the biggest thing is the pervasive belief in epilepsy as a contagion, and how that is used to justify really severe discrimination and stigma, and really sort of horrific types of discrimination and isolation of these patients, which is just remarkable because we know how easily these disorders actually can be treated.
I assume a couple hundred years ago in Europe and America, there were a lot of beliefs about epilepsy that were not true. I wonder how those are similar or different than the ones you found in Africa.
Yeah, I think it may look a little bit different because I think that in Africa, the idea of ancestral influence is very ingrained and a respected part. You consult with your ancestors as you move through your decisions and day. But the belief in more sort of negative witchcraft type of potential causes, I think, is where you would see similarities in the US and Europe and Africa.
So Deb, there's a question, a comment from Stacy Bennett. She wants to know, is there a way that people can support your work moving forward?
Oh, that's a great question. Certainly, if there's any people with interest in this kind of cultural work, I'm always reaching out to the epilepsy folks in our group, and certainly would welcome residents also being available to help consult. I'm a clinical neuropsychologist, right? So my focus is on behavior and beliefs and cognition, but I often need to consult in terms of medications and treatment and things like that. And I love to include folks, particularly students, in the project. So if you know of someone that's interested, just have them get in touch with me. And then for anyone that, knows of folks that want to fiscally support our work, Rich often talks about philanthropy supporting the department. Philanthropy also supports the DGNN group. So if there's anyone interested in doing that, let me know, or knowing of people that would be. I'd like to get connected.
And I think Will could probably put something up on the website about how to do that.
Yeah, sure.
Andrew, do you have a question?
Yeah, thanks. Sorry, I'm in the car, but Deb, I'm just wondering, the traditional healers that are often first stop, do they have any strategies that are effective? I mean, have they been able to successfully treat any of the patients, or is it a universal seizure failure if they go to traditional healers first?
It's not universal, which it's not universal. And I don't know in Uganda, of course, when we interview them, all of them say that they're 100% successful. And it's really fantastic that they will say that not only are they successful, not only can they treat it and that Western medicine doesn't work, but also that they can inoculate people against epilepsy. I mean, there's such a belief in their own in their own ability to treat. So that makes collaboration very challenging. In terms of actual efficacy in Uganda, we don't know, but there was a study in Tanzania that looked at the properties of the herbs that are commonly used to treat epilepsy, and about half of the herbs had AED properties. So there is some success. What percentage it is, and then also how many of this is just what's amount of the success is just, kids that have a seizure or two and then are done, right?
Right.
But they don't really have epilepsy. I think that's all kind of confounded, but there is some success, and it makes sense that people go there, because if you believe that this is the ancestors that are causing it, the traditional healers are the experts. They are the medium that people seek to reach and talk to the ancestors. So there really is, it's a challenge, right? And my hope is that down the road, Uganda, the government will do a better job at recognizing traditional healers. In other countries like Rwanda, there is more collaboration. And there's recognition and sort of support for traditional healers being a part of care in areas where it makes sense, right? Counseling, support, and then using them as sort of feeders into allopathic care where needed. Make sense?
Mary Gooey, Mary had a question.
Says great work.
Oh.
Oh, go ahead.
No. Hi, Deb. Thanks. You and I think, have gone to Uganda together on one of the trips, actually, but not related to the epilepsy stuff. But knowing the area and knowing how much of an impact having access to these essential services is, and knowing that there's a lot of grant support related to this type of work, are there any contingency plans if something should happen to grant funding, so people don't have a rug pulled under them, like if something should happen?
Yeah, so that's a great question. And everything, so we have frequent talks about sustainability of the projects that we do. What we don't want to do is just sort of go in there, do something, measure outcomes, get a publication, and leave, right? Like that's like the most horrible way, I think, to show up to another country. But instead, we are always trying to think about like, well, okay, we planted this epilepsy clinic. We're actually hoping to plant a second one because the epilepsy clinics are one of the most powerful ways of getting people to care. But then doing a gradual work to connect with the Ministry of Health in terms of in-kind contributions, like we're there providing support for the provider and for the medicines for these 3 years. In the next 3 years, what can we work towards having a post created, for example, by the ministry, so that we can expand the number of providers and have more buy-in to make that a sustainable project, for example. And so it's we try to think forward in how we can ensure that the work that's being done is sustainable, and also trying to do work that is shifting the belief system a little bit through community sensitization, so that there's more likely to be a snowball type of effect in education, especially if we can train the trainers.
All right, great
Thanks.
job, Deb.
Yeah.
And everyone, have a great day. Take care.
Thanks.
Bye.
Thanks, Rich.